Good afternoon and welcome to our Google Hangout. I'm Kate Lauman, social media consultant for SSM Health. Welcome to our Google Hangout. Today we're talking about women's heart health. Many misconceptions when it comes to the topic, and we think you're going to get some great advice today that you can put into practice to immediately improve your health. Now, during this chat, we'd love to hear from you with your questions. You can email in your questions to askssm@ssmhc.com. You can also tweet us. Our Twitter handle is SSM Health, or you could post on our Facebook page. Just search SSM Health. Now, as we answer your questions today, please keep in mind this is for informational purposes only. If you have specific questions about your own health, please speak with your healthcare provider. Today, we're fortunate enough to have two heart health experts joining us. We have Dr. Stephanie White joining us from St. Louis and Dr. Jane Pearson joining us from Madison, Wisconsin. And before we get to those questions from our viewers, we want to hear from our experts. So, Dr. Pearson, let's turn things over to you. Thanks so much for being with us.
Thank you, Kate, and hello to everyone from Madison, Wisconsin, Dean Clinic, and St. Mary's Hospital. By way of introduction, I work in what's called cardiac rehab, and basically my job is to help people decrease their risk of having either a second heart attack after having just had one, or preventing a first-time heart attack with special attention to patients with complicated cholesterol and blood pressure disorders. Let's move to the next slide. Heart disease is extremely common. If you can look at the slide, looking at the right side, I think that red script is the most important thing for us to remember, that heart disease is the #1 cause of death in women living in our country. That's an important thing to remember because American Cancer Society has kind of taught us to think about it from the cancer perspective. I think if you ask most women, they fear dying most of breast cancer. They've done a great job in educating women about mammogram and pap smear. We're a little behind in reminding women what actually puts them at greatest risk. We've been told that it's a man's disease, it's a disease of older people, and I will tell you, as medical director of cardiac rehab, every week we enroll someone in our program who is just out of the hospital from a heart catheterization or a stent or a bypass procedure, who is of the age 30 or 40. So this is not just an old man's disease anymore. And unfortunately, more women are likely to die of heart disease than men, dating all the way back to 1984. Though since 2000, we have seen some progress in fewer deaths from heart disease in women, but it still remains the #1 cause of death. Good news is this is largely preventable, and that's what gets me out of bed every morning. Let's look at the next slide, where we will have a collection of what's called modifiable on the left or non-modifiable risk factors for heart disease. Modifiable just means those are things that we are able to change. Of course, looking to the right, we can't make ourselves any younger. Most people don't want to change their gender, and we can't really choose our parents. So we can't do much about the right side of the column, but look at all the opportunity listed under those modifiable risk factors that we can all choose to do things in a heart-healthy way every single day. We're going to talk more about those through the conference this morning, but please remember that the most important way to decrease risk of heart attack or prevent a second heart attack is to not smoke. If you do smoke, please stop. Even staying away from secondhand smoke exposure of others is very important in keeping a heart healthy lifestyle. High cholesterol, blood pressure, diabetes, the metabolic syndrome, which is a collection of subtle abnormalities in cholesterol, blood sugar, waste, and blood pressure, constitute something called metabolic syndrome, and that is really on the rise in our country, mostly linked to the obesity epidemic. Not only does metabolic syndrome significantly increase a person's risk for heart disease, but it increases risk of diabetes significantly. We have opportunities in diet and exercise to also reduce our future heart disease risk. Let's look at the next slide. Basically, it's got a lot of good information on the slide. It takes a minute to sort of absorb it. So looking at the left, you'll see an arrow, and the bottom of the arrow is the person at the lowest risk for heart disease. The top of the arrow is highest risk. So what I like the best is the bottom little optimal risk box. And what does that mean? Optimal risk means that person is doing everything right to decrease risk of heart attack. And what does that patient look like in my office? Well, actually, I don't really see those people in my office. They're very healthy. But what I mean is, this is a person who doesn't smoke, who has normal blood pressure, not taking any medication, who does not have a history of diabetes, who exercises 150 minutes per week aerobic, who tries to follow a Mediterranean diet, who has maintained a normal blood sugar and a body mass index, that's BMI, less than 25, meaning the weight is acceptable for the person's height. Those people are at very low risk for future cardiovascular disease, heart attack, or stroke. But unfortunately, that's a really small box of us. Really, only fewer than 10% of adults in our country are in the optimal risk category. In other words, most of us has at least one risk factor for developing heart disease. As we increase that arrow, you can see that the more risk factors that a person has, the higher the risk of disease. And it's very common for people to have a collection of risk factors. In other words, people who are overweight also more likely have high blood pressure and diabetes and a poor diet. And so it's very easy to really collect many risk factors all in one person that significantly increase a person's lifetime risk for heart attack or stroke. And of course, I remind people that at the very top of the arrow is a patient who already has established heart disease. This is a person that's had a blocked artery, maybe has had a stent, bypass surgery. And that is a disease of arteries. And diseased arteries always remain diseased. And so we help those people by controlling risk factors so that they don't have a complication from that artery disease. But it's an important concept to remind people that just because they had a heart attack 10 years ago doesn't mean they're cured. It means we need to continue working to reduce their risk factors to prevent a second heart attack. Looking at the next slide is just a reminder that we all have choices to make every single day, and paying attention to what we eat, how much we eat, how we get to places like walking versus driving makes a big difference in our long-term health. The next slide does sort of a cartoon actually about what happens when we're talking about heart disease. And again, it is a disease of arteries. The arteries in our body transport oxygenated blood to muscles to help the body work. And the heart arteries are essential to keeping the heart muscle healthy. You can see in the top little picture there that artery is nice red, lots of nice blood flowing right through that artery. But in people that develop high blood pressure, high cholesterol, maybe a family history of early heart disease, over many years, that artery can start to sort of fill in, kind of like a sort of liken it to a garden hose that's been out for too long and it gets kind of lined up. And you can see that when that gets filled in with cholesterol and whatnot, there is less blood flow going through the artery, and therefore less blood getting to the heart muscle. That is a process that can sometimes start occurring in people in their late teenage years or 20s, especially in families who have a very high cholesterol problem. But it's a gradual process, and unfortunately doesn't have any symptoms. People don't know that they have this. It's a slow, gradual process. Sometimes people are lucky enough to have symptoms when the narrowing gets significant, and Dr. White will talk about that in a bit. But if that artery becomes completely closed, a heart attack will happen. The next slide helps understand that symptoms of heart disease can be different when we think about men versus women. The typical symptom is, oh, an elephant sitting on my chest, but I tell you from experience, many people don't have that, and it can sometimes be a little bit tricky. Again, Dr. White's going to talk a little bit more about those, but it's especially common for women to have some more unusual symptoms. Maybe that discomfort's in the shoulder or the arm, or it's nausea or extreme fatigue. It's not always the classic symptom. The next slide is basically a reminder of a very nice web tool that is available to all of you on the American Heart Association website, and I would really encourage you to have a look. This is basically a free assessment tool. You can give yourself a little heart assessment test to figure out what truly is your personal risk of heart disease, and then there will be actionable items that you can actually put into place to reduce your future risk. So please visit that website and see how you can help yourself today. Well, thank you very much for listening to that overview. Again, I look forward to fielding some of the questions specifically about preventing heart disease.
Dr. Pearson, thank you very much. Some really great information. We do already have some questions coming in. Before we get to those questions, though, let's turn things over to Dr. White. Dr. White, thanks so much for being with us.
Thanks for having me today. I appreciate it. Today, I'm going to talk a little bit about 10 facts that women need to know about reducing your risk for heart disease. I'm a cardiologist here in St. Louis, Missouri at the SSM Heart and Vascular Institute at St. Mary's Hospital. As Dr. Pearson said, that women, heart disease is the major cause of death. 1 in 3 women will die of heart disease, and 1 woman dies every minute of heart attack. And what we have seen lately is that there is a middle-aged group that, probably doesn't think that they're at risk of heart disease, that heart disease is rising among that 35 to 54 age person. And she talked already about, American Cancer Society has done a great job of educating the population about breast cancer, but, heart disease is even more prevalent. We need to do a better job of getting the word out about risk for heart disease. As you look across the United States, maybe Wisconsin doesn't have quite as prevalent heart disease as Missouri does, but if you look in our area and even further south, we have a great opportunity to make a large impact in reducing the risk of heart disease. I always say, and it's probably not politically correct to say this, but women are a little bit weird in the symptoms we have for heart disease. We always talk about this, very typical pressure in the center of your chest and feel like an elephant sitting there. But women can have symptoms like fatigue and shortness of breath and just decreased exercise tolerance that can be the main symptom that is a sign that there is significant coronary disease and even people having a heart attack. So it doesn't have to be that very typical pressure in the center of the chest. What's really important is to know what your risk factors are so that we can prevent heart disease. There's a way for me to calculate what my individual risk is. It's called an ASCVD risk calculator. What's important is to talk to your physician about what your individual risk is. And that's why it's important to start going to your physician at an early age so that you can know what your blood pressure is, get your cholesterol checked, and get your blood pressure checked so that we can take all of those numbers, incorporate it into this calculator that calculates what your 10-year risk is. And based on all of these numbers, if your risk is more than 7.5%, it is an indication to take cholesterol medicine. But more than that, it identifies patients who may not think that they're at risk for having heart disease, and it kind of gives you the opportunity to look at those modifiable risks that Dr. Pearson already talked about. And this website, you can see on the next slide, just goes in, types in your gender and cholesterol, and do you have hypertension, do you take medicine in it, and it spits out a number. But it's important to talk about this with your physician. We talked about knowing your numbers, and it's very important to know what your blood pressure is and understand who needs treatment. And the guidelines say that your blood pressure should be under 140/90. If you've never had high blood pressure before and you get to age 60 and you start developing hypertension, I think it's okay for your blood pressure to be 150/90. But that is our goal. And if you have more risk factors for coronary disease, and those risk factors being diabetes or kidney disease, you need to be a little more aggressive about your blood pressure management, just because it is such a risk. I think that as part of cardiovascular disease, stroke is something that is higher risk for women. More women than men die of stroke, and women have unique risk factors that lead to those risks. There is pregnancy-related complications. If you have gestational hypertension, or if you're taking hormonal therapy, or if you've had preeclampsia in the past, those are all unique risk factors for women that lead to potential cardiovascular disease. So like I said before, it's really important to know your numbers. You know, you need to start screening blood pressure at a young age, 20s and 30s, because so many people show up in their 30s, you know, with very severe hypertension, and it could have, you know, been treated at a younger age. And then, you know, sometime, you know, after that, it's really important to just get a baseline of what your cholesterol is, because as we talked about before, you know, there are modifiable risks and non-modifiable ones. And, you know, you can take medicine for blood pressure and you can take medicine for cholesterol, which, you know, makes a big impact in reducing your risk of heart disease. I think the main thing I can say is that you need to have a good relationship with your physician, and so that you can know what your numbers are and discuss what your risks are. And that, you know, when we talked about the risk calculator of, if, you know, would you benefit from taking statin therapy or not, those individuals that would benefit are those that have a higher risk of developing coronary disease. Other people that would benefit are those who have diabetes, whose cholesterol isn't as optimal as it should be, those who have severely elevated cholesterol, and those who've had a heart attack before, no matter what your cholesterol is. I get this question every day. You know, my cholesterol is perfect, but I've had a heart attack. Why do I need to be on, you know, a statin? And the recommendation is that it prevents further events no matter what your cholesterol is. Food, you know, we get this question every day, you know, what is the best food for me to eat? Well, I can tell you foods that are bad, and foods that are high in processed sugar, and people who drink a lot of soda, you know, your risk of developing coronary disease is higher. In addition, eating low salt diet is what we recommend, and as you know, Dr. Pearson alluded to before, we recommend the DASH diet or the Mediterranean diet. And just to keep it simple, if you look at your plate and you eat, the largest portion of your meal should be fruits and vegetables. Very small portion of meat. If you eat meat, it should be a fatty fish like salmon. Eating red meat should be very minimal. Those are all the recommendations for the DASH diet or the Mediterranean diet. If you look at things that the Western diet is, it's very high in sodium. And if you look at the, you know, slide on the right, you know, those foods are easy, especially, you know, having young kids. And if you start eating those foods earlier, it increases your risk of developing heart disease. So starting at a young age is important. Be active. You know, 3 to 4 times a week, getting at least 40 minutes in of activity at a heart rate that's about 80% what your max heart rate is what we recommend for good aerobic activity. And then doing some resistance training in with that is what the recommendation is. And I always tell my patients to quit smoking. It's one of the most important modifiable risk factors that you can do in order to decrease your risk of having a heart attack. You know, I tell patients who've presented with heart attacks before, if you smoke, it is not if, but when you will have your next event if you do continue to smoke. So, I mean, I really think that it's probably the biggest thing that a person can do for themselves is to quit smoking.
All right, excellent advice. We do want to make sure everyone knows if they do have any questions, send those questions in to us now. You can email them, askssm@ssmhc.com. You can also post on our Facebook page or Twitter. Just search Ask SSM. All right, we do have some questions, so let's get to those now. Dr. White, let's start with you. A couple people, this question came in from a couple different people. What if your numbers are good? The numbers that you're talking with your physician about are good, but you're still overweight and struggling to lose that weight. What should that next step be?
I think that just increasing your activity level is probably the next step. You know, numbers are great, but if you look at metabolic syndrome, part of those calculations that go into that is, you know, being overweight and what your BMI is. And just, you know, decreasing your BMI can decrease your risk of heart disease. So I would recommend my patients just to be active. Try to incorporate a better diet, maybe eat a little less. But, you know, yes, there is still a risk if you have metabolic syndrome, which is a higher BMI.
Now, when we're talking about activity, is there a goal that you like to tell your patients what they should try and do, whether it's on a daily basis or a weekly basis?
Right, I try to recommend patients get at least 3 or 4 days of aerobic activity, about 45 minutes each time. What's really difficult is when you tell that to somebody who doesn't do anything. They see that as a mountain that is incapable of climbing. So I tell patients you have to start somewhere, and I recommend starting with a walking program. Try to do 10 minutes a day. Park further away from the door. Use the stairs, not the elevator, because then they can slowly increase their activity and not really realize that they're doing more and more each day. But the goal is, like she said, 150 minutes a week, which to some people just seems impossible.
Right, like you said, if they're at a baseline of, not much activity at all. Another question coming in, Dr. White, should I be concerned with a blood pressure of 139/78? If so, what are those first steps to take to lower it?
Well, that's a very specific, number, and it's hard to know what your risk is without knowing everything else. I would say that number, without knowing any other details, I would say you wouldn't necessarily need a medication to treat that. However, if that person is not active, if that's the lower blood pressure, and maybe there have been higher ones, and maybe they have high cholesterol and they have a family history of coronary disease, it might be something that's a red flag that just other diet and lifestyle modifications need to be made, and not necessarily medication, but that is important conversation to have with a primary care physician.
Okay, Dr. Pearson, someone writing in wanting to know, is heart disease more prevalent in African American women?
That is a very good question, and the answer is yes. Actually, that is the demographic that has the highest risk of dying from cardiovascular disease, and we think that it's mainly due to an increased number of risk factors in that population. Black women have more hypertension, obesity, diabetes, and cholesterol disorders, and that altogether really does place them at a substantially higher risk of developing heart disease and actually of dying from it.
Dr. White talked a little bit about physical activity and cardio activity. What's your advice to patients, and how do you get them to take those first steps? Like Dr. White was saying, especially with those patients who, they're hearing 150 minutes, but they're at 0 minutes. What's your best advice for those people?
It's very hard to ask someone that hasn't been active to start doing something quite differently. Lifestyle change is very hard, and I see people who are really making excellent effort and commonly have maybe been able to lose about 10 pounds, and then they just plateau. Very frustrating, and I agree with Dr. White's assessment. It usually has to do with the physical activity component. And so the two pieces of advice that I remind people of is it will take a long time to get rid of it. And so we advise people not to try to lose even more than 10% of their total body weight in any calendar year, because there's a risk of regaining that weight if it's lost more quickly. So I have to remind people to be patient, which is tough because they want the weight gone and they're really trying. But that is a very good reminder. It takes time. Secondly, I think I absolutely agree with the start slow with the walking program. Younger people are able to do more and do more quickly. And so for younger patients who are otherwise healthy, except weight, I see a lot of people maybe not working hard enough. And so my favorite thing to say to people that I feel comfortable with from a heart perspective is that your aerobic exercise means panting and sweating. It's not strolling. Okay, so people tend to maybe a little bit underdo the exercise intensity component, and I remind otherwise people who've been active at least to try to work harder. And then the second thing, as mentioned, is this resistance training, which we always also call strength training. And that's a super important component to aerobic training, especially for weight loss, because muscle cells are absolutely our best friend. Muscle cells just basically consume calories and are a very important addition to aerobic exercise when it comes to maintaining and losing weight. Now, it takes several months of dedicated strength training to actually get to that threshold where you will see some more weight loss, but it does happen, and it really doesn't take much. It's about 20 minutes, 2 days a week, of going through a series of strength training exercises that result in basically trying to fire up every large muscle group in your body. So there are different little programs online and different ways that you can use either your own body weight or free weights to learn basically a routine that you can do regularly, and that is the very adjunctive aid in weight loss in people who are plateaued.
That makes sense. Thank you very much. Dr. White, a question for you. What concerns should women be looking for in relation to heart issues as they get older and enter and maybe even exit menopause?
I mean, that's a very good question. You know, that is kind of that riskier time period where patients start to develop heart disease, and we see people presenting with those symptoms. I mean, I think that, you know, again, it's just knowing what your numbers are and having that conversation with your primary care physician, knowing what your blood pressure is, getting your cholesterol, you know, checked, you know, modifying those risks. Not that that time period is that much more risky. It's just that, you know, I think sometimes people are in denial about their age, and as they get older, that they're entering a time in their life where they become higher risk. And so I think that that is the biggest obstacle, is to get them to go and have that conversation with their physician and go through those risks so that they can be screened and then intervene where those things need to be fixed.
Now, both you and Dr. Pearson have mentioned having the conversation with your physician. Do you start with a primary care physician, or do you start with maybe a cardiologist or something, something more focused with your heart health? Where does one start, and really at what age should that start?
Well, my answer is that you start with a pediatrician. Because really this is a public health issue, and I think, especially in speaking to women, you know, women sort of set the health context for the family, and so that we can really start helping our children understand what healthy food tastes like, starting, you know, right from the get-go. And I think that it's important for parents to really demonstrate healthy lifestyles by not smoking, making time for exercise, and, you know, avoiding fast food. So I wasn't trying to be silly about that answer, but it really is an important thing to start early in life. We actually have pediatric guidelines that recommend screening children for cholesterol and blood pressure. But to your point, as we get older, any healthcare professional, including, I see many people who are referred from the nurse practitioner in OBGYN when people are there for a routine gynecologic screen. It just needs to be on everyone's radar that starting early in life, if you just get your blood pressure checked at the drugstore, or there's a wellness exam as part of a workplace screening, those are just important caveats and important opportunities that people should pay attention to, because I think that we all need to take some accountability of our own health, understand kind of what we do need to know, and no, people don't need to start with a cardiologist. They should just, I'm hoping, my dream is that we can all kind of pay better attention to this early in life and start to glean bits of our own health information throughout our entire continuum of life.
That makes sense. Dr. White, anything to add to that, or we do have another question coming in for you?
I don't have anything to add. That was perfect. Start early, continue, you know, it's an early issue.
Yeah, absolutely. And the continuing, I mean, like Dr. Pearson said, you know, women get so focused with their kids and with their other activities and their other people in their family, just making sure that they are taking time for themselves when it comes to their own health. Obviously very important. Dr. White, is the risk for blood clots hereditary? Two-part question here. And if you do have them, if you do have that risk, does that increase your risk of heart disease?
So say the first part of the question one more time.
Is the risk for blood clots hereditary?
Most of those blood clotting disorders are hereditary, typically not, you know, acquired later in life. And then does that cross over to coronary disease? It's not really the same disease process, although there is some crossover there. Most times people have blood clots, you know, in their legs, and that's what predisposes them to having, you know, that's the side effect. That is the risk. If you have a blood clotting disorder, you can get, you know, blood clots in your legs, which could potentially go to your lungs. People are usually on blood thinners for that. But like I said, it is a little bit different disease process, and I don't think that risk crosses over.
All right. Another question, question coming in from Lisa. What effect does alcohol have on your heart and on your cholesterol?
It's a very good question. The most prevalent issue that I see with alcohol and alcoholism is that it causes patients to have heart failure. The heart can become very dilated and weak and not squeeze like it's supposed to after years and years and years of lots of alcohol. Now, that being said, there is a fine line between what's a healthy amount and what is an unhealthy amount. You know, I would say the recommendation for women is, less than one a day of a drink, which is okay. But everybody is different in what they're able to drink and not drink. So those are the things that I would worry about with alcohol. That it's not necessarily a disease that leads to blockages and heart attacks. It's more a risk of heart failure with high doses of alcohol.
Okay, that makes sense.
I would also add to that regarding cholesterol, people who drink a lot of alcohol can also have very high triglycerides. And that is something that we measure in the blood, and that's why the reminder is given to people who are going to have a fasting cholesterol test done to not only fast that day, but preferentially have no alcohol for 48 hours before that blood test, because triglycerides can be influenced quite easily by alcohol.
Oh, that's interesting. Okay. Dr. Pearson, you mentioned in your presentation all the education done on breast cancer awareness. Do you think it's getting better? Do you think we're getting better as women, putting our heart health first and becoming more educated? Are you seeing an improvement?
Oh, absolutely. I very much think that people are really starting to be much more progressive and aware, and I see more effort at physical activity. I see wellness programs in the workplace. I see people trying to use bicycles and walking as transportation as excellent efforts. We have a lot of work to do, but I think we're starting to actually sort of turn the ship around and help people to feel better. I think that the demographic, at least that I observe locally where we live, is that there's still a lot of obesity in our 20 and 30-year-old population and about further cardiovascular disease. It's very common that we see people of that age who are much larger than their parents. The life expectancy of that generation has actually been calculated to be a bit shorter than their parents, which I think is very interesting, and it's still a reminder to all of us that we have to keep ahead, and that really wellness with regard to healthy food and activity needs to be a priority. So I do see signs. We've got a lot of opportunity.
That's good. Well said. Dr. White, a couple different questions coming in about heart palpitations. People wanting to know when those should be taken seriously.
That's a very broad symptom. I see a lot of patients for palpitations. Palpitations can be, a simple thing, an extra beat here and there from the top chamber or bottom chamber of the heart, but they can also be prolonged heart rhythm abnormalities that can range from being very benign to very fatal. So, I think that if you're having those symptoms, if it's something new, you should see your physician and talk about it, because we can put a monitor on your heart for 48 hours or for a month and try to pick up what that is. Sometimes it's a sign that, you could have a blockage. Sometimes it's just a sign that you may have atrial fibrillation, which is not necessarily a sign of heart disease causing heart attacks, but definitely needs appropriate care and treatment. So, I think having that conversation with your physician and then trying to diagnose what those palpitations are is important.
That makes sense. We just had a question come in on Facebook from Violet. Violet wanting to know how to reduce triglycerides any other way other than medication?
Oh yeah, triglycerides are actually really fun to help people with because they are very modifiable. They can go down very quickly with small changes in lifestyle. So yeah, we talked about the alcohol. Triglycerides are very closely linked to blood sugar. So if a person has diabetes, it's important to get diabetes well controlled in order to improve triglycerides. Starting any form of exercise, aerobic exercise, also really drops triglycerides. I love to tell patients that if they just start walking 15 minutes a day, they'll take 100 points off their triglycerides within a week, and it works. Um, uh, Avoiding foods that are what we call simple carbohydrates or refined carbohydrates, which are basically things that you buy already made that aren't in meat or dairy category. So um, uh, bread, um, baked goods that you buy off the shelf in the grocery store, sweets, soda is a really big one. Just getting rid of soda and extra free sugars in the diet can really improve the triglycerides. I also remind people that have high triglycerides, maybe in the 200 to 400 range, that actually having that slight elevation in triglycerides is a marker or what we call precursor for diabetes. It's quite common that I see people who are going to become diabetic without lifestyle change who will have high triglycerides for many years before the blood sugar goes up. So it's a marker and a reminder to patients, hey, you know, gosh, I think you've inherited this tendency for diabetes, your triglycerides are creeping up. It is absolutely time to make lifestyle changes. And things as small as starting a walking program, losing as little as 5 to 7 pounds can also make a significant difference in triglycerides. Last resort, of course, is adding pills to control triglycerides, which is sometimes necessary.
Dr. Pearson, another question for you. What should a heart rate be for a woman over the age of 50? She says she's doing great. She's walking and running 5 to 6 days a week. After that walking and or running, about where should her heart rate be?
That's a very good question, and the normal resting heart rate in anybody is between 60 and 100. That's a pretty broad range. We very commonly see resting heart rates lower, even in the 40s, in people who are quite physically conditioned, especially in distance athletes. And so it's a little bit variable according to the individual and according to their aerobic fitness level. Dr. White, do you have anything else that we should think about there?
No, you hit it on the head. There's a very wide range. I mean, I think that heart rate variability is a sign of excellent cardiovascular health. So, you know, if you're having higher heart rates while you're exercising and then you stop exercising and your heart rate drops, I mean, that's a good sign. If it persistently stays elevated and takes a long time to come down, that would just be a sign that your cardiovascular health isn't where it should be. But you know, saying there is a specific number is really difficult. You have to look at symptoms and other things that are going on. So.
And it's more about that change and how fast it happens once you get done with your aerobic activity. Okay. Someone writing in asking, is it normal to feel a random big heartbeat from time to time, and what might this be? Have you heard that term before, a big heartbeat, Dr. White?
Yeah, I've heard that a lot. Sometimes people can have an extra beat from the bottom chamber of their heart. And when you have an extra beat that comes in a little early, then you wait until you would normally have your next beat. So your heart fills a little bit more, and that next heartbeat is usually what people feel is because your heart is fuller than it was on the prior beat. It beats very vigorously. And then that is that big heartbeat that people feel. It's not necessarily a bad thing. If people have a lot of them, then I would be concerned. I would see your physician so that they can monitor how many of those you're having. But every once in a while, that is not a problem.
Okay. This question coming in from a couple different people, and I'd like to get perspectives from both of you. But some people dealing with maybe gas or heartburn or even more stomach issues, whether it's nausea or IBS, dealing with those chronic conditions or on a more chronic basis, how would they know the difference between some of those maybe GERD-like symptoms and a heart attack?
Well, I'll start with that one. It's very difficult. If you look at the chest and where people have symptoms, just anatomy-wise, there's a whole bunch of things crammed into that space. your ribs, your esophagus, your stomach, your lungs, your heart. And so, you know, your stomach sits right next to your heart. So oftentimes people can think it's my heart and it's really their stomach, or they can think it's their stomach and really their heart. Somebody who's had chronic stomach issues for some time, who takes medicine for that and then it gets better, that's a good sign that it's not the heart, but it's not perfect. There's a lot of times where I see patients who have ongoing symptoms that are not being able to be treated by, you know, Nexium or, you know, whatever over-the-counter antacid. And I usually do some sort of ischemic evaluation, meaning some sort of stress test on those patients, just to make sure, like I said, because women specifically can be weird, but men too. Oftentimes, you know, the presentation, like I said, for heart attack can be, you know, reflux or chest burning. So, I mean, I think that you owe it to your patient to rule that out, and part of that is a stress test. So, you know, oftentimes if patients are having ongoing symptoms, like I said, and the medicine isn't working, I think it's important to do some sort of stress test. I don't know if Dr. Pearson has anything to add.
Yeah, no, I agree with that. That's a really, that is really tough. And acid reflux or Gird and irritable bowel syndrome are extremely common, you know. And so I think, you know, the only thing to add is that I think people do know themselves best. And most important to me is a patient who's had sort of some chronic symptoms that for unexplainable reasons have gotten significantly worse. And that may be significant. And I completely agree with Dr. White that it's hard to sort it out, and testing is sometimes indicated.
Do one of you mind going over those heart attack symptoms again for a woman and how they may slightly different than those of a man? Just so we do have those out there one more time. I know we talked about it at the beginning of our presentations, but just a reminder, what are some of those heart attack symptoms that women should be on the lookout for?
Sure, I'll start. You know, women can have very typical symptoms. Those typical symptoms are chest pressure. We usually say worse with activity, better with rest. But oftentimes those symptoms can be nausea. They can be chest tightness. It can be just fatigue and inability to do what someone is supposed to be doing. So, you know, if you're usually able to climb a few flights of stairs and trying to do just one flight, you're exhausted by the top, I would say that that could be a sign. Other symptoms would be, I said nausea. I mean, those are the big ones, I would say. Fatigue, shortness of breath with activity, chest pressure, chest tightness, a band around my chest. And then the one that I've picked up on lately, just that diaphoretic, that sweatiness that people get whenever they're exerting themselves. I mean, sometimes that's, you know, the only thing that they feel. They say, I was walking up the stairs and I just got really sweaty, and I don't ever do that. Those would be concerning symptoms to me.
Yeah, I agree with all that. I mean, the most common is chest discomfort, but in women, sometimes shoulder, arm, neck, jaw discomfort are other locations. Middle of the back is sometimes an issue, and it's really hard to sort things out because as the person, people have all of these things, and they frequently don't have anything to do with the heart. So trying to decide when it's important to get that addressed is also very hard. And as Dr. White mentioned, many heart symptoms, as you can imagine, when people are physically active, we're asking more of our heart. It needs to pump more blood to the muscles that we're using. And so classically, heart symptoms come when people are physically active and get better with rest, but that's not always the case. Okay. And I also again, think people know themselves quite well, and there is this sort of uncanny sense that something is really wrong that people will often explain, but they can't explain it, and I always pay attention to that. They seem to know. I've had people who have said, you know, gosh, I've had this weird chest pain my whole life, and on this particular day, it just seemed different, and I knew something was wrong. And so it's a little hard as the physician to say, oh, trust yourself with that, but it really is true.
That makes sense. Let's talk a little bit about clogged arteries. A couple people writing in wanting to know what's the best way to detect clogged arteries and if and how they can be reversed. once they are clogged?
I think Dr. Pearson said it best when, oftentimes people don't have symptoms until it gets to a critical stenosis, meaning, you can develop plaque in your arteries over years and not have symptoms. And then all of a sudden you start having, those, chest pain or shortness of breath with activity or whatever, and then you can develop symptoms. The best way to detect that, usually the first step is some sort of stress test. It's best to walk on the treadmill. We can do other kinds of chemical stress tests or imaging. If you're having symptoms that seem more severe, so if you go to the emergency room with chest pain, and usually those symptoms are at rest and severe, and we think you're having a heart attack, sometimes we will jump from the stress test and bypass that and say, let's do an angiogram and go into your heart to see if there's blockages. Then sometimes that decision is made. What is hard is to explain that, we can fix severe blockages by putting stents in, but that's kind of a Band-Aid, I believe. It can relieve the initial blockage. It can help people not have symptoms, but it's that process over years that has developed that plaque that has built up, and that's why, it's hand-in-hand medicine, diet, lifestyle changes that are really the most important thing in prevention. So, we have easy ways of detecting are there blockages, but, once it's there, we don't just go in with something and remove them. We can kind of relieve whatever critical stenosis is there, but it's hard to explain that there is no way for us to totally go in and remove all of the plaque. It's got to be a diet and lifestyle process to prevent progression of that disease.
I would like to add to that too, that we don't routinely do testing for, stress testing and whatnot for people that are not having symptoms, because we know that the result of the stress test isn't very valid if people are not having symptoms that are concerning us. The gold standard, the way you know for sure if there's blockage is as Dr. White said, an angiogram, but that's an invasive procedure. It's also called a heart catheterization. It involves poking a hole in the groin artery and putting some dye in the heart arteries to take pictures and whatnot. So we don't do that routinely because we don't want to hurt anybody, and there are some risks with that. So we rely on listening to the patient and getting sort of stress tests that don't involve that type of level of invasion of the body as best we can. But again, the most important thing is to pay attention to treating the risk factors. I did want to mention that in people that already have heart disease, and we know it, the other really, really important way that we actually can demonstrate some regression of plaque or plaque going away is with high-dose statin therapy. And I cannot emphasize enough, in my opinion, the statin drugs, which were first identified in the mid-1980s, are the absolute most important breakthrough in cardiovascular health in the last 30 years. There are studies actually measuring plaque done in a lab and measuring how thick a plaque is, and then treating that patient with high-dose statin and remeasuring it 18 months later and being able to literally measure that it has gotten better. May not go away, but gets better. But more importantly, any plaque that's there becomes stabilized. It sort of develops a very thick cap so that it doesn't break open, and plaque stabilization is very important and achieved with statin medications, which are also used for cholesterol.
A question that just came in via email: how do you reduce C-reaction protein levels?
Mm-hmm. I can answer that one. C-reactive protein is a blood test that is very nonspecific, meaning it can be a little bit high for all sorts of reasons. But in some patients, it's helpful information to decide whether or not we need to put someone on a cholesterol medication. In other words, having a high C-reactive protein may be another risk factor, like high blood pressure or high cholesterol when it comes to heart disease. And ways to lower that C-reactive protein, actually, I sound like a broken record, exercise, losing 5 pounds, following the Mediterranean diet, and taking statin therapy are all great opportunities to reduce that particular number.
Okay, great. A question about atrial fibrillation. Do shortness of breath and dropping blood pressure, do they correlate with AFib?
sometimes when patients have an abnormal heart rhythm and it is going too fast, sometimes the only symptom that people have is more shortness of breath. They try to, walk down the hallway or walk upstairs, and typically they're able to, but, in atrial fibrillation, they might have more symptoms. Those symptoms could be shortness of breath. Typically, patients usually don't drop their blood pressure if they're in atrial fibrillation unless there's other, circumstances related. Their heart isn't squeezing like it's supposed to. If they're sick, if their heart rate is very, very fast and very uncontrolled, sometimes their blood pressure can be lower with it, but it's not always correlated 100%.
We had a woman write in and said, thank you for going over those heart attack symptoms again with this presentation. Someone wanting to know, do symptoms typically come on suddenly, or is it more of a gradual thing?
I would say that if you are having a heart attack, it is usually sudden onset. They happen usually at rest. Patients can have chest pain or pressure or whatever those symptoms we talked about usually happen acutely, not necessarily with some sort of stimulus. That being said, that progression of disease builds up over time, and sometimes people can start developing symptoms as they go and not necessarily be having a heart attack, but can be having signs that their blockages are getting worse and worse and worse.
We have almost run out of time. Anything, Dr. Pearson, Dr. White, anything you want to leave us with today before we wrap things up?
I just appreciate everybody tuning in. I think that's really a testament to the effort going on nationwide to improve the population of our country, because again, I think that women lead in that, and we know that women make appointments for other people in their family, women bring most of the food into the house, women sort of set the health standard, and congratulations to everybody for doing that.
I don't necessarily have anything else to add. I think it's important to focus on women and women's health, and I think that prevention is the key.
All right, thank you very much, Dr. Pearson, Dr. White, for being with us, sharing all of this valuable information. Thank you to everyone who sent in questions. We got to almost all of them, but we do, if you want more information about your heart health or providers in your area, visit ssmhealth.com/live. There we have links where you can learn more about Dr. Pearson, Dr. White, and also watch this video again or share it from there. So thanks for tuning in. We will see you next time.